Ladies and gentlemen, we move ahead to the penultimate session before the inaugural ceremony that features Dr. Swan Gunn's memorial oration to be bestowed on Dr. Ajit Mullasari Shankardas. He is Director of Cardiology at the Madras Medical Mission in Chennai. He would be deliberating on the Pharmaco-Invasive strategy in STEMI, Consensus 2015 and the future. And he'll have a total time of 25 minutes. May I invite to chair the proceedings President Dr. H.K. Chopra, Professor Dev Pehlajani, Dr. B. Ramesh Babu, Dr. K. Murlidhar, S.K. Govind, and Dr. J.S. Hiramat. Ladies and gentlemen, as this is the oration, we will not be having any questions from the floor. Dr. Chopra, please.
Ladies and gentlemen, this is the most prestigious oration as I meant to you is after the name of Swan and Gans. And I was really privileged to work with Swan and Gans for almost 3 years in Cedars-Sinai Medical Center in UCLA. And my working with him was only on thrombolysis. I mean, just see, 3 years I worked only on thrombolysis. In a dog lab, in experimental lab, and clinically, and what not we did. Every protocol was created, and he was the American father of intravenous streptokinase those days. There was no TNK available. And I feel very proud and privileged that this oration is bestowed upon both Swan and Gans. Gans passed away when I was working there. And this is given to none other than our own Dr. Ajit Mullasari, who had a tremendous contribution in the pharmaco-invasive approach in the patients of STEMI. And he gave a very nice consensus statement published in the Indian Heart Journal recently, as well as in JAPI. I'll request all the chairpersons sitting on the dais here to please come forward to bestow upon this material after the name of Swan and Gans upon Professor Ajit Mullasari, who had a tremendous contribution in India on pharmaco-invasive approach. Pehlajani, Hiramat, please come forward. Murlidhar, everyone. Let's give a big hand to Dr. Naveen. Please give this token of appreciation to Ajit Mullasari. Govind. I'll request Mullasari to please give his oration now.
Thank you, Dr. Chopra, for two things. One is inviting me here for this prestigious oration, and I'm pretty humbled by this. And two, for setting up the tone for what I'll be talking in the next 20 minutes on behalf of me and Thomas on where we go with pharmaco-invasive therapy in this country and maybe worldwide, especially in low and middle income countries, which has 80% of the STEMI problem. Before we start, we go into what is the problem in India, and if you can clearly see the problem is that we have about a lot of patients with STEMI, and if you look at the estimate in India, it's about 3.5 million patients with STEMI. And if you compare with the United States, it's about 0.3 million, 10 times more STEMI with limited resources. And this is expanding day to day, and 1/4 of these patients will be less than 40 years of age. It's very typical to see a 22-year-old MI in India, which is not seen anywhere else in the developed nations. Now, if you look at primary angioplasty, which is the state of treatment for treatment of myocardial infarction worldwide, and you look at what is the number of patients who get this in India, realistically in 2013, we did about 25,000 primary PCIs in about 1,000 cath labs. You look at last year's data, it's about 50,000 primary PCIs. You just divide 3.5 million by 50,000, you get a number of less than 2%. So 2% is not real. So what we are looking at is for the 98% of the population as to what we need to do. And clearly, that's what I'm going to say. What is contemporary data? We were part of the CREATE registry, which was run by Salim Yousaf and published by Dennis Xavier in the CREATE registry, which was in 90 centers in 10 regions of the country with 50 cities. And what we found in 20,000 patients, that 60% of patients came with STEMI, which is different from the European or American population of patients who come, where less than 1/3 present with STEMI. 58% got thrombolytic, 8% got PCI. Unfortunately, the median time from symptoms to hospital was 6 hours. So that's the problem, 6 hours from pain to arrival to hospital. 4% traveled by ambulance. Most patients paid by treatment for themselves, and low CABG and PCI rates. This was the data in 2009. Now, I work in a large tertiary hospital. We looked at our data, which we published in the Indian Heart Journal, of one-year outcomes of close to 10,000 patients of ACS over 5 years. And clearly what we found that our outcomes in terms of patient types was similar to the European American group, which is about 30% came to STEMI. Was that we were doing a better job? Answer is no. The problem is that you're in a tertiary hospital and most STEMIs go to smaller hospitals. So the referral pattern to a tertiary hospital is likely to be more European, and so the problem is not seen as much in your tertiary hospital as is compared to the primary and smaller hospitals where people with chest pain go to. So STEMI needs to be treated at the smaller hospitals. The second issue is this was the paper which Cindy Grimes and Keeley's presented in the Lancet of 2003, which changed the whole treatment of STEMI from thrombolytic treatment to primary PCI. 23 randomized trials, large meta-analysis, and 2% reduction of death, about 4% reduction of reinfarction, a 1% reduction of stroke, which made PCI the treatment of choice for STEMI in most countries of the developed world. The reality is that after 2005, there was a 44% increase in number of cath labs in the United States, but the access to those cath labs was 1% more. So clearly, cath labs flourished in urban-centric hospitals and didn't go to where the access was. And this is going to be a bigger problem in countries like us, which are large, which have more villages and small cities, and clearly where the cath labs come in urban-centric hospitals dictated by economics. So what happens again for outcomes if you look at in a good tertiary hospital, like many of the good hospitals in this country, we looked at our 10-year data of primary PCI of more than 4,000 patients, and we found clearly that we could deliver the same outcomes that the American and European centers could, with a death rate of about 5% overall, 2.5% for patients with no shock, and the shock patients who were referred late had more than 50% mortality. But this is our islands. We cannot create these hospitals all over the country because they're cost intensive and we don't have that many trained people at this point of time to look after all these hospitals all over the world. If you want to go home with one slide, this is the slide we should go home with. If you reduce your time in the initial part of MI by 30 minutes, you're going to reduce your mortality by 60%. So time is essence. You move it to B to A reduction of 240 minutes, you're going to reduce mortality only by 10%. So clearly, what you need to do is reperfuse your patients, irrespective of your reperfusion type, early. And that's the key learning that we need to learn from this slide. So we were clear at that point of time, 5 years ago, that pharmaco-invasive strategy must be the strategy we should all look at. And the strategy involves giving thrombolytic reperfusion and following it up with an angiography within 3 to 24 hours, as that seemed to be a more real strategy. The data was very clear worldwide that the pharmaco-invasive strategy is better than a standard therapy. That means you fix with reperfusion, send the patient home, and get maybe 5 days or 10 days or a treadmill-based angiography. That was inferior to what we had here. So me and Thomas, with a lot of our cardiology colleagues, put together a not-for-profit organization called STEMI India, looking at how we can deliver services of STEMI in this country. And we proposed a simple program. Try to give primary PCI for those who enter tertiary hospitals and whom you can give a door-to-balloon time of less than 90 minutes. Realistically, 1% of people today in this country. 99% gets a door-to-needle of less than 30 minutes with a good thrombolytic and follow it up with an angiography plus minus a PCI within 24 hours. So that was the proposed program. So what we did, we piloted it in a small place in Coimbatore. So you can see in the center is the main hospital of Coimbatore, the red one. Then there's a red grid. And the red grid has 30 minutes of transfer time. So those hospitals which were referring to the central hospital were told very clearly, the physicians, that you just refer for a primary PCI. Don't confuse yourself. Don't lyse those patients because you can shift quickly and we can give a door-to-balloon time of 90 in that hospital. Anybody in the green grid was told very clearly, it's too far away, the distances are big, thrombolyze all of them, unless the patient is in shock or hemodynamically unstable, shift for primary PCI, shift for pharmaco-invasive strategy in 24 hours. So clear strategy to physicians, We got the government ambulance to sign in for the first time in India, the 108 ambulance. We got the physicians to follow a total protocol. And over a 6 months period, we published this paper in the Heart for the first time, saying the systems of care is possible in a country as diverse and difficult in terms of healthcare and limited resources in India. Following this, we simply put this whole data together, and I published this thing in the Interventional Cardiology Clinics of North America, that in countries like South Asia, Africa, Indonesia, and large countries which treat 80% of STEMIs, pharmaco-invasive strategy is the only strategy you can give and deliver very well in patients. The next issue was, at that point of time, about 2 years ago, there was no data suggesting that pharmaco-invasive was as good as primary PCI. So we ran a head-to-head trial of pharmaco-invasive versus primary PCI in 200 patients in south of India, with the primary objective to check whether both these strategies are equal, and the secondary objective, which is more worrying for physicians, that whether a thrombolytic followed by an angiography will create a bleeding. We wanted to rule that out and to look at the safety part of the study. 5 centers in south of India, all in diverse states, in diverse populations, some urban, some rural, but all tertiary centers, put in 200 consecutive patients, divided into 2 groups, primary PCI and pharmaco-invasive strategy. What did we find? The 30 days was the endpoint primary. The secondary endpoint was STEMI major bleed. We followed up the patients for 1 year, and we followed up all of them for concomitant medical treatment and their compliance to medications. Interestingly, the data suggested the A arm, which was the pharmaco-invasive strategy, 7% had insignificant disease at the angiogram, typical of large thrombus burden patients in young MI. Second thing, the open artery, that is the artery with good TIMI flows, despite a lesion being there, was seen in 82% of patients, despite 240 minutes of referral. And this is contrarian to most of the American and European data, which says up to 3 hours. So clearly Indian patients may be different because they may have more thrombus and they may respond better to a tenecteplase type of treatment. The second thing was the thrombus was much better at the time of the angiogram in the pharmaco-invasive arm than the primary PCI arm. The procedural TIMI flows at the time of the procedure, that is the angiogram, was better in the pharmaco-invasive arm, and fortunately the bleeding risk was very, very low. And the reason was that most patients in the pharmaco-invasive arm in Indian hospitals went for the radial approach, and radial approach circumvents the chance of bleeding. So clearly you put a radial and the pharmaco-invasive looks good. So what was the conclusion of STEP-AMI, and we followed this up to 2 years, and though there was a slight trend for primary PCI to look a little better, especially in higher risk patients, in the first 30 days, at 2 years, all the outcomes look similar between the pharmaco-invasive and the primary PCI, and this was again subsequently published in the Heart in terms of the STEP-AMI trial. Almost at the same time. Yeah. I thought we have 20 minutes. I was supposed to speak on 2 topics.
Yeah, 1 minute more.
Dr. Nanda, I was supposed to speak on 2 speakers.
Huh?
I used to need to speak on 2 speakers. Thomas's talk also.
Oh,
so.
yeah, sorry.
Sorry.
Then go ahead, yeah.
Sorry. So the New England Journal at the same time showed the same data and clearly showed a similar outcome for fibrinolysis versus primary PCI in this group of patients. So clearly the data from STREAM added more justification to what we did, that clearly the outcomes are the same in patients of the STREAM data with the STEP-MI in terms of early outcomes and late outcomes. The conclusions for STEP-MI was similar, that clearly that it's a good and comparable clinical outcomes with primary PCI, there's lower thrombus burden, better TIMI flows, gets 80% infarct-related artery patency, and even when the total ischemic times is 4 hours, and clearly it's a good strategy to alleviate logistic or geographical. Following this, we upscaled that to the Tamil Nadu STEMI project, and the first time we bought in the government insurance. Tamil Nadu covers all patients now for STEMI, for thrombolytic, pharmaco-invasive and primary PCI. So we got the government to fall into line, and this was a protocol which we published in the BMJ, the protocol which was the Tamil Nadu STEMI project, which now has completed 1 year follow-up, 2,500 consecutive STEMIs with 4 hubs between various groups of hospitals, and a picture like this a class A or B hospital in the center, which is a thrombolysis or a primary PCI 24/7, or a thrombolysis during the night hours and primary PCI in the day hours, a C hospital which just refers the patient, just as an ECG, and a D hospital who lies and shift the patient. 4 clusters, we started with 5, ended up with 4 clusters, a mix of government, not-for-profit, rural, private, 100 hubs with a mix of all sorts of hospitals. And this is what I want to show you. This is what happens. This is Odanchatram, which is about 126 kilometers from Coimbatore, which is a large red dot. Patients used to have an ECG done and told, we can't treat STEMI, please go. And used to travel by car or bus or ambulance by 4 hours by the time the STEMI is completed. Now, we put the systems of care in the small hospital. It's a large mission hospital in the south of India, receiving at least 3 MIs a day. And what happens? The patient is a smoker, has an insurance card which allows access to health care completely free of charge, gets a chest pain at 11:45, arrival in 12:15, ECG at 12:25, transmitted by telemedicine to a hand phone in the hub hospital, completely wired and completely all data stored on the, and there's an inferior wall MI. The patient is now thrombolized, confirmed and thrombolized with streptokinase. Post-lysis ECG is taken at 3:15, which shows complete settling of the STL elevation. And now, when the patient is stable, transferred after 3 hours by ambulance. The transportation takes 4 hours. By the time the patient comes to the Coimbatore main hospital, which has a cath lab, there's slight chest pain. And that's what happens typically with thrombolysis, that the artery starts re-occluding. And many thrombolytic patients get re-infarcted because of the initial effects wearing off. So patient goes to the cath lab, gets a PCI in 10 minutes, is discharged on the next day. The entire bill is paid to the insurance government of Tamil Nadu. And clearly, you gave world-class care by putting in 2 strategies, getting your insurance, getting your ambulances, putting telemedicine services, and helping out these patients. So I don't want to go into more details of this, but we have now data which is just put into the Lancet for publication of 2,500 patients of STEMI, and 96% of patients were having streptokinase as treatment. I'd like to just say that the dose to needle, despite a diverse population of patients, was still 31 minutes in Tamil Nadu. So very good thrombolytic treatment achievable. Unfortunately, that is not true for primary PCI. Even the good tertiary hospitals are 105 minutes. And so I think in a general care, it will be much worse. What also happened, we ran a pre-interventional cluster and a post-interventional cluster, and more patients started getting PCI. Now, I'd like to conclude by this one little slide, which shows on the right lower panel of our 2,500 patients. If you look at, you give the best care, which is primary PCI for almost 800 patients, you can see the MACE events is 3%. 2.1% death and 3% MACE. You go to the worst treatment, which is the left upper part of this whole slide, which is no treatment, which about more than 12% of patients still got, despite systems being there, almost 13% mortality, 13% MACE with 10% mortality. You go to what we call possible treatment in India, which is streptokinase thrombolysis. You go to the picture which is just below the no treatment. We still have a MACE in events of 10% with a 9% mortality. You go to the top right-hand corner, and that is our strategy, pharmaco-invasive, and the strategy shows a 3.5% MACE, 3% mortality, very comparable to primary PCI. This is not a randomized trial, but an all-comer 2,700 patient, and clearly shows that that is the best. So this is the paper we published in API for the consensus statement with a large number of physicians saying that thrombolytic with a facilitated treatment is the best, and among the thrombolytics maybe tenecteplase and retiplase would be the preferred thrombolytics, provided costs come down. And this was edited by Paul Armstrong and Franz van der Waal from the European Society and the American Society, saying no STEMI left behind in this sort of a treatment. We have now concluded with these last 2 papers as strategies, and there's a framework paper coming in the next Indian Heart Journal with CSI and API endorses this system of care. And developing of a system of care for low and middle income countries, the STEMI India model is now in Global Heart as a strategy for all low income and middle income countries. Thank you very much for your patient hearing.
Hello. Yeah. Congratulations, Ajit. Great work. I think something like this had to come from India one day, and it has happened. I have personally being always a kind of a fan of pharmaco-invasive approach for the feasibility and the type of care that we offer. And now that it has become so scientific, well proven and well documented, it should be the care that we should offer to all our patients.
Ajit, I think it is a very good work that you have presented. I feel that what comes out of this, that STEMI management is not an individual's or individual hospital's effort. STEMI management is a program. It's a complete program in which the society, the government, the governmental agencies in a city, and the lay public, and the hospitals, and then the doctors and their casualty departments had to be involved to develop a program of transporting the patient, deciding who should receive the pharmaco-invasive, who can receive the primary PCI. And I think that until unless it's a complete program, I don't think we can deliver the best of the care to our STEMI patients. And I'm very happy that at least Tamil Nadu government has taken a step forward and given a lead to the rest of the states in the country. Today, I think our Honorable Minister of Health is going to be here. I think this message should go to him that this should be kind of a blanket permit given to all the states where the STEMI patients should receive the optimum treatment. Now, you gave a data of that there are 3.5 million STEMI patients in the country. As a matter of fact, the world literature says there are 6,000 STEMI patients for 1 million patients in a developing country. So that should translate into something like 6 million patients. So I think what you are estimating is probably an underestimation. But point I'm trying to make, there are millions of patients who should receive this treatment, and there has to be a comprehensive, complete STEMI program over the nation.
I think it's a very brilliant expression by Dr. Pelajani that STEMI management is not one man's protocol. It's a matter of strategy. And we feel very proud that Dr. Mullasari and his team has given a very nice joint report and a statement which is coming in Indian Heart Journal, I think in next issue, which is going to say what are the strategies. It has a lot of medical legal implications. So I think once we quote this consensus statement, it is going to have a tremendous medical clinical implications, and for a proper strategy, we will definitely help in reducing the morbidity and mortality. Let's give a big hand to Dr. Mullasari
Thank you very
for
much,
his most outstanding
Mr.
presentation.
President. Ladies and gentlemen, we'd like to congratulate Dr. Ajit for being conferred with Dr. Swan Guns Memorial Oration.